is project. There we go. I was just waiting for the recording to start. Okay, thank you for joining us today. My name is Dr. Catherine Muir. I'm a neurologist and epileptologist, and I work at CHEO, the Children's Hospital of Eastern Ontario. And this is the first session in our new series, which is starting today, Epilepsy Across the Lifespan. And today we're going to be, this is a focus on epilepsy in children and youth topics. Today we're going to be talking about when to prescribe. And we have Dr. Toro Perez, who's going to do the didactic presentation for us. Just to remind everybody and let you know if you're new to ECHO, ECHO is a technology-enabled case-based learning program. We will have a short didactic presentation, and then the majority of the time will be spent discussing a case. As these sessions are meant to encourage learning, we will always ask the spokes, so all of you joining, to give input on the case first before the members of the ECHO Hub team weigh in. The case today is from my practice, but going forward, I really encourage everybody to submit cases from your own practice. It's always a lot of fun to discuss cases that people bring to the sessions. A couple of housekeeping things. This session is being recorded, as you saw. We always have to be careful not to disclose any personal health information during these sessions. We encourage you, if you're comfortable, to turn your camera on and unmute yourself when you're speaking so that we can build a sense of community here. There's also the option, if you would like to say something, to put it in the chat, and we'll monitor the chat throughout the session. Please feel free to reach out to tech support if you have any issues. We have Adam here joining us today for support. Okay, so we're going to begin with the introductions. I'll call your name as I see you on my screen, and if you could turn on your camera, unmute yourself, and tell us who you are and where you're from. If for some reason you can't unmute, you can just write in the chat. Okay, so we'll start with Vivek Barun.
Yeah, good evening. I'm Dr. Vivek Varun. I'm adjunct neurologist from India. Thank you.
Great, thanks for joining us. And Mai Haikal, nice to see you again.
Hello, I'm a pediatrician mental health specialist from Egypt and currently a pediatric trainee. It's always a pleasure to be with you. Thank you.
Thanks. Abir Salim.
Good afternoon. My name is Abir Salim. I'm international medical graduate, pediatrician from Egypt too, but I live in Canada for a long time now.
Great, thanks for joining. Nage Haiba.
Hi, my name is Naja Haiba, neurologist consultant, Almenia, Almenia Hospital, Egypt.
Great, thanks for joining. Rashid Salim.
Hi, I'm a pediatric neurologist, United Arab Emirates.
Great, thanks for joining us. And Heidi is here again. She put in the chat that she is a nurse from BC Children's Hospital. Kat Gibb. Kat Gibb is a nurse practitioner in pediatrics from McMaster Children's Hospital. Thanks. Nika Gabriel Job.
Pediatrician from Nigeria.
Thanks for joining. Kumari Kusaram.
Hi, I'm a pediatrician from Jamaica.
Great, thanks for joining us. Santosh Balagopal. And Sienna Jiang. Okay, and then we've just had Derek Rajkumar. Okay, and I can see AQ Rana is still connecting. So you guys can always put in the chat who you are and where you're from. All right, we'll move on to the members of the ECHO Hub team. Shakira Baker.
Hi, everyone. My name is Shakira. I'm the Education Administrative Coordinator. Welcome.
Sadia Siddiqui.
Hi, everyone. Thanks for joining. I'm the Program Coordinator for Echo Epilepsy.
Juan Toro Perez.
Hi, I'm Epilepsy Fellow here at CHEO in Ottawa.
Nkema Onuwiwu.
Hi, everyone. My name is Nkema. I'm the Program Manager for Echo Epilepsy. Welcome.
Sarah Healy.
Hi, I'm a Research Coordinator working with Dr. Mura at CHEO.
Adam.
I'm Adam, here to provide tech support at Sick Kids.
Sandy.
I am an educator with the community agency Epilepsy Ottawa.
Stephanie.
Hi, I'm a nurse case manager in the neurology clinic here at CHEO.
Thanks. And I thought I saw Erin Lawson. Are you here, Erin?
I'm here. Hi, apologies, I don't have a camera at the moment. Welcome, I'm an interprofessional educator for Echo Epilepsy.
Okay, thanks, Erin. Okay, so let's get right started with our case presentation. I'll turn it over, or sorry, our didactic presentation. I'll turn it over to Dr. Toro Perez.
Thank you so much. So today we will be talking about when to prescribe, but we need to keep in mind some consideration before that. Okay, so I have only relationship with the transition grant leading by Dr. White in Ottawa, and also as an investigator in the Argus trial for Clinisol. This program has received financial support from the Ministry of Health and Long-Term Care in the form of educational grant. So a part of the what I have mentioned before above, I don't have any potential conflict of interest. The learning objective for this presentation is learn how to approach seizure-like episodes, learn how to diagnose epilepsy, and identify factors to consider when deciding whether to start or anti-seizure medication. So this is something that we have seen before. So it's a seizure. So we need to keep in mind the definition of seizure. It's a transient occurrence of symptoms and signs due to abnormal, excessive, or synchronous neuronal activity in the brain. We have two most important tools for the diagnosis is the history. Nearly 90% of what we have for the diagnosis is history. And now with the new technology, video is so important to clarify events that could be related with seizure or not. And also we have supported EEG and also, if it's necessary, imaging. So I will share a video, and people are invited to choose if this is a seizure or not. I don't think so that yet the poll. I will show first the video.
I'll get you a treat, you guys. I think he's pooping.
Okay, so now what do you think, people? What do you think? This is a seizure? Yes, no. We have 30 seconds to see your answer. We are close. Great. Okay, so what we are seeing in this video, so if we are keeping I will forward again the video. We are seeing these movements of both upper extremity and this eyelid blinking, but the patient appears to be totally engaged with the conversation. So agree, this is not a seizure. So we have now another. I will share the video, and people, you can tell me if this is or not a seizure. Okay. Focus in the upper extremity movements. So what do you think? Is this a seizure or not? I would like to hear your comments, please. We will give a little 5 to 10 seconds more. Please. Perfect. So 86% said that this is seizure and 14% said that this is not a seizure. So maybe someone who said that this is a seizure, could you tell us what kind of seizure are these events? And why you said that this is a seizure? Great, Vivek. So agree. So as we are seeing in the video again, look at this. The patient is having 3 times episodes of arms abduction. So this is more in keeping with infantile spasms. Okay, so also we need to keep in mind that there are some seizure mimics and are related in this topic: migraine, stroke, syncope, breath holding spells, and behavioral episodes. So as I told you at the onset, nearly 90% of the information that we will get will support our hypothesis. So and based on it, we will request some supported investigations. Okay, so Adam is not running. Okay, so also sometimes we have some seizures, but all seizure, it doesn't. If we have a seizure, it doesn't mean that we will have epilepsy, or that means that we have to treat. So there is a group of seizure that is in the book of provoked seizures. We need to keep in mind the main condition that will be able to trigger seizure activity, like hypoglycemia, hypocalcemia, alcohol withdrawal, other kind of intoxication, and fever and toddlers. So correcting the provoking factors is not needed an anti-seizure medication. Okay, very common in our population, 2 to 5% of the children could have seizure related with fever. Complex febrile seizures could have focal involvement in 4%, lasting more than 15 minutes, and more than one seizure in 24 hours. So at least 20 to 25% of the febrile seizures are complex febrile seizures. And the prognosis is based on if they are simple or complex. So 30 to 40% will have a second febrile seizure, and 1 to 2% has the risk to develop epilepsy after a simple febrile seizure. But this risk increase if we are in front of complex febrile seizure, up to 4 to 12%. Also, we are a part of the provoke. We need to keep in mind that there are some acute symptomatic seizures. In this case, stroke, traumatic brain injury, and infections are the most important conditions related with this kind of etiology, and may need anti-epileptic therapy acutely. The long-term anti-seizure medication use only will be considering after epilepsy is established. So in this case, what we can do, open, we have provoked, the terminology of provoked seizure, febrile seizures, and symptomatic, acute symptomatic seizures. We need to keep in mind the definition of epilepsy. So is defined by the International League Against Epilepsy as at least 2 unprovoked seizures 24 hours apart, or 1 unprovoked seizure, and the probability of further seizure for at least 60%, or the diagnosis of epilepsy syndrome, so some kind of condition that don't fix in the first and the second definition, but they're typically for some group of peoples. And the investigation that we need to keep in mind is everyone with unprovoked seizures need to have an EEG, urgent, if not returning to the baseline or fluctuating level of consciousness. And we also need to keep in mind that 70% of patients with new onset seizure will have a normal first EEG. And based on the definition of the epilepsy syndromes, we need to keep in mind that based on the age, we could be seeing some of the group of the typical spike wave complex. In this group, childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, and also generalized tonic-clonic seizure alone are in this group with the spike wave complex. But also there are some other groups with specific centrotemporal spikes that are called self-limited epilepsy with centrotemporal spikes, or right now, or select. So investigation, neuroimaging is really our most important tool. Brain MRI is the most important imaging study, but CT scan will be the most important imaging if we have the suspicion of intracranial high intracranial pressure. So in this case, brain MRI in 3T protocol is recommended for non-urgent epilepsy. When to treat epilepsy? So considering the risk for further seizures, if we have only 1 seizure, the chance of recurrence in the next 5 years is 50%. So, and this lasts for at least one year. But with 2 seizures, 24 hours apart, the chance of recurrence in the next 6 years is 80%. So another thing that we need to keep in mind, if we have only 1 seizure and we have EEG abnormalities in the context of epileptiform activity or abnormal neuroimaging, that increase the risk of 80%, the chance of recurrence in the next 5 years. In nocturnal seizure per se, increase more than 50% the chance of recurrence in the next 5 years. So treatment is recommended after 2 unprovoked seizures, or when the risk is equal to that of someone with 2 unprovoked seizures. In this part is the second definition. So 1 seizure plus EEG, abnormal EEG, or MRI with some structural anomaly with predispose the risk of second seizure in 60%. Also, the epilepsy syndrome should be considering the treatment based on the frequency, based on the parental preference, based on association with another kind of risks. So most epilepsies require treatment, but there are some conditions that they are infrequent, like childhood epilepsy with centrotemporal spikes, Panayotopoulos, override seizure plus, and in this case, we have to consider in a good relationship with the parents. When we are talking about decision medication, we need to consider a drug which decrease the frequency or the severity of the seizures, treat the symptom of seizures, know the underlying epileptic condition, and the goal will be maximize the quality of life by minimizing seizures and adverse effects. So now we are going to move some short cases, and also I would like to hear your answer. So this is a 15 years old who has had a single generalized tonic-clonic seizure. So you are awaiting further investigation, including EEG and MRI. What will you do? Will you prescribe anti-seizure medication? Yes, no, it depends. Okay, so what people say, no, it depends. Okay, I think that the majority of them are totally agree that we will not start a decision medication. So I think that for non-start is okay. And it depends. It depends if we are in the context of 15 years old who has a generalized tonic-clonic seizure. And what about if the EEG show up the complex spike and wave? And what about if with the history we find more spell like a myoclonic? Usually myoclonic seizures are not recognized as a first step after the patient had the generalized tonic-clonic seizure. So I agree with you, not start in waiting for the EEG study, and MRI should be considered after that finding. Or it depends on the center also. We have another question. Before go to this second patient, any other approach from our staff, Dr. Muir, in the first case, what will you considering?
Yeah, I think in the first case, I agree. I wouldn't prescribe with a single seizure. And so say like, no, you wouldn't prescribe, or it depends. It depends on the history. It depends on the investigations.
Thank you so much. Well, we are moving to the second case. This is 15 years old who has had a single generalized tonic-clonic seizure, and the EEG show left temporal epileptiform discharge. MRI show increased signal and atrophy of the left hippocampus. So people, go ahead and let us know what is your answer. Would you prescribe anti-seizure medication? Yes, no, or it depends? Perfect. 100% agree with that. That is correct. So if we have the description of a single generalized tonic-clonic seizure and a 15 years old, but the EEG show left temporal spike, maybe what we are seeing is the last part of the focal seizure because the MRI is showing atrophy of the left hippocampus. So that means in this case, we are in front of a focal non-motor onset seizure with bilateral tonic-clonic progression. So, and etiology is related with the left hippocampus atrophy and also the EEG showing the left temporal spikes. I agree with you. Next. Okay, now we have another case, another group of people. So this is 8 years old who have 3 nocturnal seizures characterized by a shocking gargling noise, drooling and pulling of her face to one side. Her EEG shows bilateral independent centrotemporal spikes with horizontal dipole, suggestive of the diagnosis of self-limited focal epilepsy or of childhood. So I would like to hear your great. Vivek, you are so active. You were doing correctly with all the answer. What do you think the rest? Do we have to prescribe? Yes, no, or it depends? I think that we have ready. Okay, yes, no, it depends. Okay. We are divided 50-50, so I'm going more in this point. It depends. It depends of what? Depend of how frequent are them. depends how is impaired the cognition and how is the EEG. So the EEG set that shows only bilateral independent centrotemporal spikes, but we need to clarify if the recording based on the international in the American clinical neurophysiology guidelines, we have to be aware if they are occasional, rare, occasional, frequent, abundant. So in our case, we need to keep in mind all that features. Also, we need to be engaged with the parents. If the parents are open to treat, if the seizures are so isolated, at least one or two per year, really no problems with the school, is developing well, maybe avoid to treat. But if the seizures are coming from, for example, 3 nocturnal seizures, all of them in 1 month, and the parents are noticing some deterioration since the cognitive point of view, obviously, we need to think about if treat or not, or maybe think about any other condition. With this case, do you want to say something more, Dr. Muir?
No, I think you covered it well.
Oh, thank you. Okay, so take-home message for this presentation. Epilepsy is diagnosed by history. At least 90% of information is history and videos. Videos are so important now, supported by investigations that will be requested based on our hypothesis. Treat provoked seizures by removing the provoking factors, and most epilepsy requires anti-seizure medication. So this is the referral pathway for our community support. So we need to keep in mind that referral for the community support can occur at any point during the patient treatment where there is no local agency. Epilepsy Ontario can provide the support. Thank you so much for these slides prepared by Dr. Andrea Andrade and Dr. Maria Nuri at Children's Hospital of Western Ontario in London, Ontario. Thank you so much.
Okay, so before we start the case presentation, we have time for a couple of questions. Did anybody have any questions for Dr. Toro Perez about how to diagnose seizures, epilepsy, and when to consider starting medications? Heidi says if you decide, oh, I lost it. Heidi says if you decide to treat provoked seizures, how long would you treat? And can you give some examples of instances where you might treat provoked seizures?
Okay, provoked seizures really, if they last less than 5 minutes, we don't need to treat. We need to observe. But if the seizures go in the way of status epilepticus, we have to follow the protocol for status epilepticus. So some kind of intoxications, we have to do, for example, if one baby or one child intake some specific substance, we need to clarify what kind of substance is to try to work if this substance has or not any other antidote to try to avoid that. But at the same time, the follow will be as the same of status epilepticus. Seizure lasts more than 5 minutes, we have to go with first line treatment, benzodiazepines. If after 5 minutes the seizure doesn't stop, a second line treatment, also benzodiazepine, and then we need to continue with the third step as levetiracetam or phenobarbital or fosfenitoin. It depends on the institution where you are. That will be one of the most.
Yeah, I would agree with that. Like, obviously, we treat any kind of provoked seizure if it's any kind of seizure if it's status, we treat it. The other situation where I would treat provoked seizures, or maybe kind of the approach to provoked seizures, is that you need to treat provoked seizures until the provoking factor is removed or has settled down. And so for the majority of provoked seizures, there's an initial provoking factor. So say like hypoglycemia, and you may or may not need to treat the seizure as status. You correct the hypoglycemia, you're done. You don't need any further therapy. And then there's something, so like if a child were to have a stroke, you can have seizures that are caused by the stroke. And in those children, sometimes we get away with just treating sort of the status or maybe treating once. Sometimes seizures can persist for a couple of days as the edema sort of peaks from the stroke. And so then I would put them onto seizure medication for days up to maybe a week out. But at that point, the edema is improving and that provoking factor has resolved. And so I would take them off the medications. And then an example of one where I leave them on for longer is intracerebral hemorrhage. So blood is very irritating to the brain. And so those ones often have more difficult seizures to control initially. And those ones I would leave on, I usually leave them on for about 3 months just because that's sort of when we see them in follow-up. But I tend to discharge those ones from hospital on seizure medication because of how irritating the blood is, to give time for that to settle out. Same thing if you have seizures from a brain infection like cerebritis, we see seizures from. And if the children have seizures from cerebritis, I treat them with anti-seizure medications until they're done their course of antibiotics. So thinking that the antibiotics are finished, the infection is resolved, the provoking factor is gone. There is a question here about nocturnal seizures, thinking about treating nocturnal seizures and the risk of SUDEP. So maybe going back to that, the brief case that you presented, Dr. Toro Perez, of the child with selects. What do you think about treating children with selects to try to decrease the risk of SUDEP?
Yeah, I totally agree with the risk of SUDEP with patients, but the risk of SUDEP, if we have two groups of patients, focal and generalized, if the patient has focal seizures, really the risk of SUDEP is low compared with patient who has generalized tonic-clonic seizure or focal to bilateral tonic-clonic seizure, where the risk of SUDEP is really high, and they increase if they have more than one generalized tonic-clonic seizure per year. This risk is increasing more. So for sure that generalized tonic-clonic seizure, it depends of the context, depend of the theology, we have to treat. And also there are more information about SUDEP that is not the topic, but there are some measures to avoid some or to protect our patients from SUDEP.
Yeah, I agree with that. I think that there's a risk of SUDEP that comes with any diagnosis of epilepsy, and that includes selects. But if you look at what is the actual risk in different types of epilepsies, the risk of SUDEP in selects is so low. So I would say overall, I approach starting medication as a shared decision between me and the family. And so I will counsel everybody with a new diagnosis about the risk of SUDEP and where I think their child falls within that kind of risk, which for selects is quite low. So I've never started anybody on anti-seizure medications just based on the risk of SUDEP in selects. I definitely have started people because parents are just very worried about seizures in general and don't want their child to have any more. Okay. There's a question here from Vivek Barun. How long do you treat seizures associated with AIE? What does AIE stand for? Do you want to type it in the chat or unmute and tell us? Selects is self-limited epilepsy with centrotemporal spikes. So what we used to call benign relantic epilepsy, we now call selects. It's a new change.
Epilepsy.
Autoimmune encephalitis. How long do I treat seizures associated with autoimmune encephalitis? Yeah, that's a good question. That's another one where I tend to leave them on medications a little bit longer because I'd like to think the provoking factor, so the encephalitis, has settled down. So I'd say sort of weeks to months, depending on how they're responding to the immunotherapy.